Hello guys, this side your Dr. Masman, and today we will study chapter nephrology. And here first we need to see the approach. And approach first thing is ultrasound. So what all things we can see in the ultrasound? It could be like kidney size, symmetry, its cyst, tumor, metastasis, okay, anatomical things. These are all the things. So in this what we see is we see the kidney size is decreased in chronic kidney disease, right? And kidney size will be normal in acute kidney patient, like acute kidney injury, right? So in this what we see if we see any enlarged kidney, right? If there are any chronic kidney disease with this, if we see any of the enlarged kidney, then what all things we can see? We can see amyloidosis, we can see diabetes mellitus, and we can see PCKD, right? So what we can see here is if things are asymmetrical, if I find in ultrasound things are asymmetrical, that means it's chronic, right? So now what we can see, it was the first point. Second thing what we can see is suprapubic aspiration, okay? If it is more, okay, then also we can rule out it. If it is more than second morning midstream, then also we can rule out in the approach. Third thing, we can see the KFT, and in this there could be like either serum electrolytes could be present or not present, right? In fourth, what we can see is fourth and fifth. There are 2 points in this. There is DTPA, second is DMSA, right? DTPA means P is there, right? P means perfusion. So perfusion functional test we can see in this, and DMSA means M means morphology. So we can see morphology, and DMSA, A means anatomy. So in this we can see either morphology or the anatomical defect. So this is how we can have the approach of the nephrology. Now second what we can see is the kidney, okay? It receives 20% of the cardiac output, right? Normal urine output is 1 liter to 2.5 liter, right? Now if it is more than 2.5 liter, for example more than 3 liter, then we will call it as polyuria, okay? If it is less than 400 milliliter, right, then it will be oligouria. If it is less than 100 ml, okay, then it will be anuria, right? Now let's see the ideal time for the urine test. When can we do the urine test? Ideal time, it will be second morning, right? And also it has a specific gravity which is 1.020 to 1.030. So this is the time of the specific gravity. It should be between this, okay? Then we have fixed specific gravity which should be 1.010, right? Now if we see the increase in the specific gravity, which could be SIADH or it could be diabetes insipidus. So there could be only two things, right? If the specific gravity is increased, right? So now there is a rule which we call as 40-5-1 rule, either 40/5/1 rule. In this what do we have? See, if it is more than 40%, then we will call it as dysmorphic RBC, right? So it was 40. 5 means if it is 5% acanthocytes, right? Or it could be 1% single RBC. If you find any of the three features or more than 40% or more than 5%, that means it is hematuria, which is due to what? Glomerular cause, which is also called as nephritic, right? Now the most common cause of hematuria, what it could be? It is kidney stone, right? Which is isomorphic stone, we also call this, right? Now there must be some things which you have already heard about the cast, right? What is cast? So whenever you have RBC cast, that means it is nephritic, okay? Whenever you have WBC cast, that means it is pyelonephritis or allergic interstitial nephritis, right? Whenever you have hyaline cast, that means it is TAM horsephal protein, okay? And also in the hyaline cast there can be dehydrated or it could be normal. Fourth one is broad granular cast or waxy cast. Waxy has come means it is chronic kidney disease, right? And broad granular cast, that means it has a poor prognosis, right? And then in cast we can have one more cast which is pigmentous muddy brown cast, right? Muddy brown. In this there could be two things, either it could be ATN or AKI. ATN means acute tubular necrosis, AKI means acute kidney injury, right? And at the end we have DTPA versus DMSA scan, right? So this was all of the cast. Now let me tell you some buzzwords. Okay, like if this come, you have to just put this answer and you will get the right answer. For example, if there is a old man, okay, nocturia, incontinence, or dribbling of urine, right? Like drop of urine from the pen. Okay, if all these things are there, that means it is talking about BPH, benign prostatic hyperplasia, right? If it is asymmetric or waxy cast, right? In waxy cast, what will be there? See, what I told you there was CKD, right? But here, if it is asymmetrical or waxy cast, here it will be chronic pyelonephritis, right? If it is a child with a edema, decreased albumin, or it is fever, that means it has minimal change in disease, right? If it is uremic factor, triphasic wave, or altered sleep attention, means decreased attention, it is uremic, it has uremic factor, right? So it will be uremic encephalopathy. See, uremic factor means uremic, and decreased sleep alteration or decreased attention means encephalopathy. Okay. Fifth is if you have HIV, or it could be sclerosis of glomerulus. Okay, HIV plus sclerosis of glomerulus, that means it is FSGS, focal segmental glomerular sclerosis. Sixth point is if you have a chest pain, increased ST or troponin could be present or not present, but KFT is deranged, right? That means it is pericarditis. See, because it has chest pain, KST is increased and a KFT deranged, right? Seventh point is froth. If you see anytime froth or foam, okay, that means it has something to do with lipid. Okay, it would be lipid urea, and also it is called as nephrotic syndrome. Okay, whenever you have semen in urine, then it means it has a syndrome called DHAT syndrome, right? Now comes to the agenesis, right? It could be unilateral or bilateral. Okay, if you have any kidney which is left out, okay, or you have a hypertrophied kidney, okay, and a person can't play the sports, okay, that means it is unilateral. And whenever all these things are there, but person has died, it is death has come, that means it is bilateral agenesis. Okay, now comes three things. What is horseshoe kidney? See, horseshoe kidney is the one which is the most anatomical defect. Okay, now come the two things: kidney tumor either in children or in adults. Whenever it's children, that means it is Wilms tumor or nephroblastoma, and whenever it's adult, that means it is RCC. Okay, now comes the test. If I have to do the test, then what do I have to do? Either what will do, I have to do the estimation, right? Three things are there. First is glomerular function, second is tubular function, third is renal blood flow. Okay, three things are there. I have to estimate these three things. So in renal function test, whenever I have estimation of first is GFR, which is glomerular function. In this I will have five things. First, what will I do is, first I will check creatinine clearance test. Second, I will do is inulin clearance test. Third, I will do is Cockcroft Gault formula. This is important. Then MDRD equation, and fifth is EPI cystatin C method. This is the best method among all which I have told you right now, right? Then comes second is tubular function. In tubular function, what I will do is I will do a test which is called as water deprivation test. Okay, this is used to assess distal tubular function, DI. Okay, water deprivation test. Then comes third is renal blood flow. Okay, in renal blood flow, what will I estimate? I will estimate PAH, means para amino hypurate. These are the three things. Okay, what does para amino hypurate does? It is measures renal blood flow. Okay, so these were all the things about basic idea which I gave you. Now we will know the things. What is cystic kidney disease, right? This is also called as ciliopathy. In this, first of all, what do we need to know is what is ADP CKD. Okay, then what is ARP CKD. Okay, third one we have is MCKD, MUC1 or UMOD gene. These two genes are there. Then comes nephrothesis. Then fifth one is MSKD. So these are the usually five things. We will study one by one all the important things which are there in this. Okay, then comes first is what I told you is ADPK PCKD and ARP CKD. Okay, AD means adult. Okay, and AR means infant. Okay, in ADP CKD, what we see is first do one thing is make PCKD out. Okay, PCKD, there are 4 letters, so write 4. Then write polycystic kidney, that will be 16 letters, so write 16. Okay, then what do we have here is, in this we have polycystin. Okay, in this we have PKD1. Okay, which is higher risk than PKD2. Okay, then this is AD, right? Means autosomal dominant. So in this there will be 2 things. In this it will be genetic, so it will, in this there will be incomplete penetrance, and also in this there will be variable expression, right? In this it will start. And also first let's see about ARPCKD. In ARPCKD we have is infant. Okay, in that chromosome was, it was like 4, 16. Here we will have a 6. Okay, there it was PKD1. Here it is PKHD1. Okay, H is the one which has come here, and here there it was polycystin. Here it will be fibrocystin, because there will be fibrosis, right? So in this what is there, we have cyst plus fibrocystin, and whenever this will be there in the kidney, then we call it CKD, and whenever this is there in the liver, we call it CLD. Patient usually die in 1 year, right? And also about ARPCKD, we can diagnose it antenatally with ultrasound, either it's oligohydramnios or pulmonary hyperplasia, and also nephroptosis, right? Now there are some things which are common in all of them. It starts usually from B, right? So in B, what do we would like to know here is, in this it will be there in boys from B, black people. Okay, bilateral cyst, BP will be increased, bicuspid valve, biliary cyst. Okay, these are all the things start from B, and also berry aneurysm. Okay, in this the one thing is lung is not involved. Okay, most common organ is kidney. If they ask you most common, extra renal will be the liver. Okay, and the least is SAH, right? Okay, so in ultrasound, what we can see is screening and diagnosis. We can see multiple cysts, and also we can see non-contrast CT, which will be more sensitive. Okay, now if we diagnose it, we have one criteria called as Raven's criteria. In this, see, first we need to know 3 things. First is 15 to 30, then 30 to 60, and then it's more than 60. Whenever you are 15 to 30, you will have 2 cysts. Either it could be unilateral or bilateral, no matter. Then comes 30 to 60. In this there will be 2 cysts. Also it will be there in each of the kidney, right? And whenever you have more than 60, that means it has 4 cysts. Okay, so in second one, which I told, 30 to 60, so in total there will be 4 because there are 2 cysts in each kidney. In more than 60, there will be 4 cysts are there in each kidney, so it will be in total 8. Treatment will be supportive, tolvaptan, fluoroquine, and debulking surgery. So this is all the things which we do it here as a treatment. Okay, and now in AR1, what we need to see here is the kidney, shape of the kidney. Okay, this will be horseshoe kidney. Okay, in this there will be fusion of kidney at the lower pole. Okay, and also in this there will be risk of renal stone. Also we can have here is medulla sponge kidney. In this, when we do a IVP, we will find a flower vase appearance. So this is all the things which you find here is. And also in this there will be medullary cystic kidney, tubular sclerosis, and von Hippel-Lindau syndrome. This will be in AD. In AR we have nephroptosis. Okay, so I have basically told all the differences. Now let's talk about urolithiasis. In urolithiasis, everything will be 4 liter water, 4 mm or less. Okay, and it will be 4 weeks, which is like 1 month, right? So whenever we have calcium oxalate crystals, this is the one which is most common, right? Then we have uric acid crystals, which is of no shape or rhomboid, right? Then we have struvite crystals. Struvite means coffin lid. Okay, so we have coffin lid crystals. Then we have Christine crystals. Christine crystals means 2 are there, so that means that would be a hexagonal, right? So most common is calcium oxalate. Uric acid crystals have no shape. Struvalite is coffin lid. Fourth one is crystal, which is hexagonal. Okay, and there are few names which they called as with another names also, like triple phosphate stone, calcium ammonium urate, protease stone, staghorn stone, and also the important one is alkaline urine. So these are all the words which come here. Okay. Now let me tell you about some of the points, like hematuria after diarrhea whenever it comes. So in this it will be, if there is a disease HUS, so in this, in ultrasound it will be normal hematuria after diarrhea. And whenever you have renal vein thrombosis, so in this it will be enlarged. About HUS, this is the most common in India. In the world we call this E. coli 0157 S7. And also in this there is a Shigella dysentery, which is type 1. Okay. About typical HUS and atypical HUS. In typical HUS only supportive. Whenever you have atypical HUS, eculizumab you give, right? Okay. Second point is, whenever you find fibromuscular dysplasia, in this what will you see? You will see strings on bead appearance, right? Now comes TTP, thrombotic thrombocytopenic purpura. Whenever you find this, you will have a classical pentad. In pentad there will be neurological feature, fever, thrombocytopenia, hemolytic anemia, and renal failure. 5 things you will see. Okay. So after ultrasound, when ultrasound is done, what you see usually, first you will do is what? Doppler ultrasound. After Doppler ultrasound you will do is isotope renogram. Okay. Then you do is MRI studies. Okay. And whenever you have a urine districts test you do, if it is negative, then it's porphyria, nothing. If it is positive, then you have two things: either it's colored or it's colorless. Whenever it's colored, then it's hemoglobinuria. Whenever it's colorless, then it's myoglobinuria. See, heme means colored, so whenever it's colored, that will be heme, right? And whenever you find a kidney stone, you will see cystine crystals, which I told. And also they can ask you the color of the urine. So in this, what are the things, parameters? You will see chemical content, you will see concentration, you will see the pH, right? Okay. So I have covered all the important points also. Now let's go about congenital glomerulonephritis. What is this? See, in this you have 3 things: NPHS1, NPHS2, and TRPC 6/9. Whenever you have NPHS1, S1 means first we will talk about this, okay? Then 2, and then a rest. In NPHS1, what is there? See, it is starting from N, right? So it will be nephrin, okay? N is first, so we are talking about first. So first will also start from F, so it will be Finnish type of nephrotic syndrome. Okay, so this was all about first. Then is second, NPHS2. Okay, S2 means second. So in first one we took N first, right? Now we will do second, that is we will take P, which is podocin. So in podocin what we do is podocin, and also at the end we have a S, right? So that's in second. So steroid resistance nephrotic syndrome. Okay, so first is first, which is started from F, which is finished. Now we are talking about second. So S, that means steroid resistance nephrotic syndrome. Then comes TRPC 6/9, which is alpha actinin, which is congenital FSGS. Okay. Now whenever you have overt syndrome of renal failure, so this will be deteriorated by more than 70%. Okay. Whenever you have CRF with anemia, okay, and you want to do the treatment, so in that case what will you do? See, the most important one is ferrous carboxymaltose. So it is very important, ferrous carboxymaltose, and chances are there for come. Then it will be recombinant erythropoietin, then it will be pegged RBC, then roxadustat, right? And then comes 2 things. Okay, either it's 2 types of hematuria there: synpharyngitic, second is delayed. In synpharyngitic, what happens? This is the one which develops in less than 1 week. Okay, and it has what? IgA nephropathy or Burgess disease. That is synpharyngitis. And whenever you have delayed hematuria, that means it will develop after 1 week. In this, there will be PSGN and HSP, right? So these are the basically 2 things. Now comes syndrome, right? We have 2 syndrome. First is nephrotic and nephritic. So first we will talk about nephritic syndrome, right? Nephritic is one what? It is the one which is proteinuria less than 3.5 gram per day, right? And in second thing is it will have hematuria. This is very important, hematuria, which means RBC cast will be there it will have anemia, BP will increase, and fever will be there. Hematuria, oliguria, azotemia. Okay, azotemia which will increase the BUN. Okay, and it will be up to 1 gram per day. And it will be seen in non-vegetarian, protein powder, and high protein diet people. Okay, this was all about nephritic syndrome. Now let me talk about nephrotic syndrome. And nephrotic syndrome means O means protein which will be more. O is there, so that is more. So protein urea will be more than 3.5. L means in this there will be lipid. Okay, in this there is a PLEAC, plaque, right? P is protein, L is lipid urea. Okay, E is edema, A is albumin which will be decreased, and then comes C. C is coagulation which will increase. In this there will be mild to moderate proteinuria. Okay, now we talk about nephritic syndrome. In nephritic syndrome we have a mnemonic called PURI. P is PSGN, A is Alport syndrome or anti-glomerular basement membrane, which is Ghost positive syndrome, good pasture syndrome. Okay, then is third is RPGN, fourth one is IgA nephropathy. Okay, so this was all about nephritic. Then we have nephrotic, means we have three things: MM, not S, MMF. Okay, so MCD, MGN, FSGS. Okay, so these were all differentiating, but there are two things which are common in both of them. Okay, see, in a state or in a country, what do we have? We have, okay, we have MPs and we have DPs. For example, like DGP, like all these things are there, na? So they are common, right, in every state and all the stuffs. So we can remember it MPGN and DPGN. Okay, so this was all about this, and now let me tell you about minimal changes. This is very important. In this we have two things, three things we have normally. See, light microscopy, okay, immunofluorescence, and electron microscopy. Light microscopy and immuno, they both are normal, but in minimal changes in electron microscopy is the one which will have loss of food process, right? And this is the one which usually students do mistakes, so we need to remember it. Okay, and there are something about minimal change in this. First of all, it is the most common cause of nephrotic syndrome in children. Okay, and in this there will be selective proteinuria, and it has a good response to steroids. So these were all the things about minimal change disease which I told. Now we have is FSGS, which is a part of nephrotic syndrome. Okay, so in FSGS also I told you previously also in the buzzwords that whenever you find FSGS, so what should be your goal? You will first of all see HIV plus you will see sclerosis of glomerulus. Okay, so here I will tell you we have HIV, which is HIV associated nephropathy. This is the collapsing type in HIV. Okay, and this is the one, see, in minimal change it was giving good response to steroids, but this is giving poor response to steroids, right? And whenever you see in electron microscopy or light microscopy, you will find sclerosis and hydrolyzation. Sorry, hyalination. Okay, so this was our FSGS. Now let's talk about MGN. And MGN, this is the one which is associated with cancers. Okay, systematic disease, hepatitis B and C. Okay, so now right now I have covered minimal change disease, FSGS, and MGN. MGN, again I am repeating, cancers, systematic disease, hepatitis B and C. Okay, and spike and doom pattern. Okay, MGN, right? So about nephrotic it is finished. Now let's talk about nephritic. In nephritic I told mnemonic PARI, PARI. So we will start from P. P is PSGN. Okay, so in PSGN what is there? First thing is it is group A streptococcus beta hemolytic, right? In this it is a part of rheumatic fever, GABHS. Okay, group A streptococcus. In this there will be sore throat or skin. In this there will be Coca-Cola urine. Okay, in this there will be decrease in C3. Okay, there will be lumpy bumpy appearance, because in this there will be subepithelial humps, self-limiting, and the main appearance here is starry sky appearance, right? So about A was of Alport syndrome, right? In Alport syndrome, what is there? It is defect in the glomerular basement membrane, collagen type 4. 4 is very important, right? and then we have COL4 and A5. Okay, and there will be history of recurrent hematuria, and this X-linked disease, important. It is there in the girls usually. It is a triad. If you remember this triad, Alport syndrome will be solved. So we have anterior lenticonus, then we have SNHL, and then we have nephritic, because right now we are talking about nephritic syndrome, right? So about Alport also we are done. So now let's come out the second A, which was IgA nephropathy. In IgA nephropathy, this is the one which has IgA deposit in mesangium, right? There in Alport, it was in the glomerular basement membrane, type 4. Here it will be deposit in mesangium, right? Here the most common cause of nephritic syndrome in developed countries, right? And also this is associated with HSP, Henone-Schönlein purpura. Okay, usually it's there in children, right? Now comes the good pasture syndrome. In good pasture also, there see two things. Good means in Hindi we call as G, good. Good means gurda. Gurda means kidney, right? And pasture means P. P means फेफड़े. फेफड़े means lungs, right? So gurda plus kidney. So whenever the two things meet, we call as good pasture syndrome, right? So after this, let's talk about MPGN. Okay. So in MPGN, see, these were the two things about P and A, which I told you, right? So now let's right now I am talking about the common one, which I told, MP and DP, right? So in MP means when you have MP, the MP wants we all to go in a track, right? So it will be tram track appearance, right? Then comes SLE nephritis. Okay. In SLE nephritis, first of all think of, like I told about MPGN, now think of DPGN. Okay. In DPGN, this is a part of SLE nephritis. Okay. And in SLE nephritis, we will have type 6 we have, fourth one is DPGN. In type 1 we have minimal, second is mesangial, third is focal, fourth is DPGN, fifth is membranous, sixth is advanced. Okay. In first three there is no symptoms. Then we have type 4, which is DPGN. DPGN is the one which is the most common type which is diagnosed. Okay, in this there will be wire loop capillaries will be there in DPGN, and also in this there will be ABCD. Anybody can deposit, that means full house effect. So in DPGN there will be wire loop capillaries, full house effect, and it is the one which is most commonly diagnosed. Okay, and in the last six, which is membranous and advanced, they are the one which have CKD like symptoms, right? So this was all about MPG and DPGN, which is common in both. So now we are talking about diabetic nephropathy, right? In diabetic nephropathy, what is it? Okay, first of all, the most common, if you ask the most common, that will be diffuse. Okay, and if you ask the most specific, okay, common is diffuse. Usually, people diffuse, that is common. Specific is one, the nodular. Okay, whenever you have nodular one, that is specific. Now we are coming about the third one, PA. PA was done RI. R means what? R was RPGN, right? So in RPGN, what is there? First of all, let's see the hallmark. About RPGN, the hallmark is crescentric GN, glomerulonephropathy. Okay, crescentric glomerulonephropathy you will find in RPGN. Okay, it is the one which is most dangerous. It is the one which has worst prognosis, and it is the one which has complication of other nephritic syndrome and vasculitis. Kidney failure will be there in less than 2 weeks, right? Now comes hypocomplementaria, right? It will they can ask you about all except for, we must know there are the three diseases. In this there will be hypocomplementemia. Okay, so which one is that? First is PSGN, right? PSGN about peri PSGN. Okay, then comes our common wala, which is MPGN. Then is third, infective endocarditis. So three will be like this, right? So let's talk about further. Okay, in further we have to see the AKI, which is acute kidney injury. In acute kidney injury, we have three things: pre-renal, renal, and post-renal. In pre-renal, what do we need to know? It is the one which is before sepsis. So kidney before sepsis is pre-renal. Intrinsic is the one which is renal. Post is what? Post means POST. Just take out POST. Prostate, PROS. Prostate ureteric bladder. Okay. So these were the things which we need to know. And also in this you can see like urine, for example, sodium urine. In pre it was less than 20, in renal more than 40, in post it could be variable. In this there could be hyaline. In pre-renal we can see hyaline cast, in renal we can see muddy brown cast, in post it will be normal, right? And treatment, question has come, so in this the treatment will be isotonic crystalloid 0.9% NaCl. So this is what we need to know about AKI. So now let's see about the features and causes. In the causes, it can be there in the sepsis, first thing. Second is HRS, hepatorenal syndrome. It will be hepatic and renal, both joined. Then comes PRS, it was HRS, now PRS means pulmonary renal syndrome. Okay, pulmonary things will come here. Then comes fourth is snake bite or scorpion sting. Okay, fifth one is heart failure or kidney failure. Then comes Chinese herbal medicine. Okay, it could be aristocolic acid or Balkan nephropathy. Okay, so this was all about the normal causes. Now we will move for about medicine causes. More it will be like multiple myeloma. Okay, and in multiple myeloma we can see hypercalcemia. This has a question come. Then comes rhabdomyolysis. Okay, in this also there will be hypocalcemia. Okay. In this there will be hypocalcemia. In multiple myeloma it was hypercalcemia. Okay, and when we do contrast we can do CT MRI. Okay, sickle cell anemia, drugs what we can give is cisplatin, amphotericin B. Okay, then comes the important parameter. See, urine will be decreasing in it, in AKI. Okay, but what will increase? Creatinine. So there is a very old question which usually asked is rifle and difference between rifle and KDIGO. Rifle means 5 things. R means risk, I means injury, F is failure, L means loss, E means ESRD. And KDIGO means K is kidney, D means disease, I means improvement, G means global, O means outcome. So this is the difference between two, right? Now we have 3 stages in it. Either it's serum creatinine or it's urine output, right? So in creatinine and output, what is there is, first we need to see like in how much times it has increased. For example, in stage, I am now talking about only serum creatinine, which I told that serum creatinine increases and urine output decreases. So how much time it has increased? See, if it increased from 1.5 to 1.9 times, okay, or you can ask 1.5 to 2 times, then it's stage 1. If it is from 2 to 2.9 times, which is 3, with that will be stage 2. Okay, and if it is 3 times, increased by 3 times, then it's stage 3. So usually in stage 1 it will be within 7 days. Now I told you about urine output, which is decreasing. So how much it is decreasing, this we need to know. In first and second stage it will be less than 0.5 ml, but in first stage it will be less than 5 ml in last 6 hours. Second stage last 12 hours. In third is less than 0.3 ml, which will be last 24 hours. So 6, 12 and 24, right? So now we have stages. We have four phases. Firstly, initiating, like whenever we initiate anything. Then is ODR. Okay, O means oliguric, D means diuretic, R means recovery. Oliguric means less urine output. So this will be 28 days. AKI, which is acute, that is reversible. CKD means chronic, it is not reversible. Okay. So they can also ask you about the markers, kidney injury markers. We have some markers like alanine aminopeptidase, ALP, osteopontin, cysteine. Okay, so these all are the markers. But which one is the one which is not a marker is acid phosphatase. Remember it. Then comes tumor lysis syndrome. In this syndrome, everything will be hyper. For example, hyperuricemia, hyperkalemia, hyperphosphatemia. But there will be one thing which will be hypo, that will be calcemia, right? Then we have treatment. In treatment is usually supportive. Okay, we can give antibiotic also, like renal dose. Okay, and then what we can do is we can give IV fluid. Okay, but not in heart patients. We can give diuretics, multivitamin infusion. We can correct the electrolyte imbalance. Okay, and we can give sodium bicarbonate, and also we can give a hyperkalemic metabolic acidosis. So these were the things. Now we must know the difference between AKI and CKD, right? So let's see about AKI. What AKI is reversible, which I told CKD is non-reversible. In AKI, what is there? First of all, it's in this there will be no neuropathy, no renal osteodystrophy, nothing, right? In this, the kidney side is normal because it's just acute, right? In this, the main thing is to be remembered is corticomedullary junction CMJ, which is intact. It is not lost. It is just intact because it's acute, right? And it is symptomatic. And in dialysis, what we see whenever we do dialysis in AKI, okay, we see refractive increase in potassium. We can see uremic pericarditis. We can see uremic encephalopathy, and this is the one which not respond to supportive, right? So let's talk about CKD. In CKD, there will be broadcast, okay, and in this there will be neuropathy. In this there will be renal osteodystrophy. In this is the one which is irreversible and progressive. In this, the kidney size will be decreased. In this, the CMJ, cortical medullary junction, will be lost. Okay, and in this, in treatment, what we have to do is dialysis and kidney transplant, right? So in order to do the kidney transplant, first we need to estimate the GFR. See, in GFR, it is from G1 to G5. Okay, so how do we see? Let's start from G5 to G1. Okay, G5 is C15, less than 15. Whenever you have first of all it's less than 15, then we have 30, 60, 19, more than 90. So G5, G4, G3, G2, G1. Okay, G5 less than 15, G4 15 to 30, G3 30 to 60, G2 is 90, G1 is more than 90. So whenever you have G1 means normal, and whenever you have G5 which is less than 15, that means it is kidney failure, right? So whenever you have G4 and G5 which is severe, so in this that means it will be dialysis. And whenever you have G1 to G3, that means it has prolonged extension of grade. Okay, so this is how the things are. And then we see the CKD. The most common cause is diabetes, okay, which we also call as diabetic nephropathy, right? In this we have like A, B, C, D, E, K. Like this we have extension of grades, right? And then let's see the treatment. How do we treat it? About G1, G2, and G3. Okay, in this first of all we see A. Okay, in A means A, B, C, D, E, K. I told grading, right? In A, what do we do it? In this, first of all, we have A1C, which is controlled sugar. Okay, it should be less than HbA1c should be less than 7%. In this, there should be SGLT2 inhibitor, which prevents the progression. Then we have to stop sulfonylurea. Then metformin should be in metformin. If it is less than 45, then decrease the dose. If it is less than 30, then stop the dose, right? So 3, and then fourth one was the insulin. Okay, in insulin we give 80% of calculated dose, and dose should be decreased. Okay, so that was about A. A is control sugar, and second is BP control. So how do we control the BP? ACI inhibitors or ARB. Okay, if potassium is increasing, okay, then we stop. Okay, ACE and ARB. If it is mild, see normal how much we have, 3.5 to 5.5, right? If it is mild increase, for example 5 to 6, then do not stop ACE or ARB, just add diuretics. But whenever it's severe, okay, moderate to severe, then stop ACEI, okay, and give what? CCB, calcium channel blockers. Okay, depends, clonidine, okay, selenidipine, okay, like this. Then comes C is cholesterol control. In cholesterol control we have statins. So what is that? HMG CoA reductase inhibitor. Okay, in this we have target TG, which should be less than 150. Then we have vitamin D. In vitamin D we have injection, tablets, soft gelated capsules, shackets or shots. These are the things which we can give. Okay, how much vitamin D? 60,000 international unit once or twice in a week, right? Then E we have is erythropoietin, which is CKD anemia. Then we have K is kalemia correction, okay, which could be like calcium gluconate, insulin, salbutamol, K binders, okay. And also in this we can give is, in kalemia correction we can give patiromer, right? So these were all the things which we have about grading, which I told. Okay, treatment of G1, G2, G3 like this. And now we are talking about clinical features. In clinical features, what we can see is we can see neuropathy. In first of all, we have 8 things: CNS, heart, endocrine, skin, okay, GIT, nails, lungs, bones. So in clinical feature of CKD, in CNS it's neuropathy, then dialysis dementia, then carpal tunnel encephalopathy, okay, then we have restless leg syndrome, okay, B12 iron deficiency, and the most common cause of convulsion is water intoxication. So and neuropathy is the one which is most common also, right? And whenever it comes to heart, in CKD it's the most common cause of death is heart. In this there could be AMI, arrhythmia, heart failure, pericarditis, all these things can be there. Then comes endocrine. See, some things will be decreased, something will increase. What will increase in CKD? Prolactin, gynecomastia, amenorrhea, galactorrhea, all these things will increase. Rest two things will decrease. What are two things? Testosterone and insulin. Testosterone will decrease, then that will lead to infertility. Insulin will decrease, that will lead to what? That will increase diabetes, and that will increase hyperglycemia, obviously. Then comes fourth is skin. Okay, in skin what do we have is we can have dryness, itching, tumoral calcinosis, induration, hyperpigmentation. Okay, in this we have CKD plus warfarin. Okay, that means skin necrosis, calciphylaxis. Okay, this is what we can see. In GIT there can be factors like uremic factor, GERD, hiccuping, peptic ulcer disease. This can be there. Then we have nails, half and half nails. Then we have lungs. In lungs we have pleural effusion. Okay, then when it comes to bones means decreased activation of vitamin D. Okay, then it was decreased activation of vitamin D, and whenever it's increased, parathyroid hormone is increased, then we have secondary degree hyperparathyroidism. Okay, in this there will be osteitis fibrosa cystica and bone tumor. Okay, in this there will be metabolic bone disease, which will increase risk of fracture and dislocation. Okay, and also there is one thing, adynamic bone disease, which will decrease in bone turnover. Okay, now comes the UTI. In this there will be cystitis and pyelonephritis. First will be E. coli, then Klebsiella, then Proteus. And in this the treatment will be fluorochlorine, nitrofurantoin. Okay, then comes pyelonephritis. So this was all about the which I told was CKD. Now let's talk about pyelonephritis. In pyelonephritis, there is acute and chronic. In acute there will be more symptoms. In chronic there will be less symptoms. In chronic there will be asymmetric U-shaped scar, thyroidization of the kidney, right? So what all things we can see here? Let's talk. In this you can see expected questions can be, for example, we can have warfarin plus CKD. Okay, in this we can see half and half nails. Okay, and also in this we can see tumoral calcinosis. Okay, Terry's nails, which can be there in CLD. Okay, then comes the dialysis. How do we see dialysis? In this, see, it's also called as renal replacement therapy, RRT. In this, either it could be transplant or it could be dialysis. So most common is hemodialysis. And then also the most common or ideal one is the AV fistula, means artery and vein fistula, which is also called as arterialization of vein. Okay, then there will be central vein and AV graft, right? And in this the heparin, this is added to prevent clotting, right? And also in this there could be complications. The most common complication is hypotension in dialysis. Okay, and there could be an expected question also, which could be a dialysis disequilibrium syndrome, which is also called as reverse urea effect or cerebral edema. Okay, and this just there will be cerebral edema due to shifting of the fluid, and this can be also prevented by one thing, which is short first session, which is of 2 hours. Usually each session is of 4 hours, but in this dialysis disequilibrium syndrome the session will be of 2 hours, right? I told you about the fistula, and also heparin is the one which has been added here, right? And also you can see like it's determined by a ratio, urea reduction ratio. Also there could be chronic complications we can see, like amyloidosis, bone diseases. Okay, we can have some indications also. Okay, so the indications, the most one is refractory and hyperkalemia. Now let's see about kidney transplantation. Two things are there, either it's live donor or it's decreased donor transplant. Whenever you have live donor, means live someone is donating, then this will be of 14 years. Okay, the best donor will be your bro and worst donor will be your wife, right? Whenever it's deceased donor transplant, in this it will be of the 10 years, and in this you need to match the things first. Okay, but if it is, see, it's from 0 by 6 to 6 by 6, this is the thing. Whenever you have 3 by 6, that's the minimum match. Whenever you have 6 by 6, it's the perfect match, right? But in case of poor match, it should be avoided, but in India we can do, like, that's not a big deal, right? And now comes about the most common infection after kidney transplant or any transplant. It is CMV. Okay, CMV, we also in this we called as owl's eye inclusion bodies. Okay, in this the most specific is polyoma virus. Most common fungal will be pneumocystitis. Okay, in this the malignancy can be of skin and lip cancer. Okay, and yeah, about kidney transplant, what I told, and also in this there can be, we can see the treatment like therapy. In this we can give ATG and LM2zumab. So ATG is anti-thymosin globulin. About maintenance, we can give steroids and immunosuppressant, right? Then comes Bartter syndrome. In Bartter syndrome, what this is what, it is AR auto. Okay, then it is the defect. This is what they ask is defect is of sodium potassium 2 chloride co-transporter, and in this there will be no hypertension, right? Now we have like two things are there whenever it's acute or hyperacute. Whenever it's acute, it is type 2 and type 4. Whenever it's hyperacute, it's type 2. We have triple therapy in it. First is cyclosporin, second is prednisolone, third is azathioprine. Okay, and also in these two syndromes are there. For example, we have Alport syndrome and NPGN. Alport syndrome is the one which do not reoccur. MPGN is the one which do reoccur. Okay, and in this we have a syndrome called as Liddle syndrome. This is the one which is associated with hypertension and hypokalemia. Okay, then we have chronic kidney disease conditions where the size is increased. So we have, usually we see APC, right? But it's not APC, it's APD. A is amyloidosis, P is polycystic kidney disease, and D is diabetic nephropathy. Okay, and why it is increased, like causes of granular contracted kidney. Then we have three things in this. Two are symmetric, one is asymmetric. Symmetric one is chronic glomerulonephritis and benign nephrosclerosis, but asymmetric is chronic pyelonephritis. So this is how we can see. And now we have the last one of the last part is diabetic nephropathy. In this there will be microalbuminuria. Then we have in this two things are there which are common: diffuse and nodular, DN, and diabetic nephropathy, DN. D is diffuse and is nodular. Then we have road traffic accident. In this there are three types are there: type 1, type 1, type 4. In type 1, serum potassium will decrease. Type 2 also sodium potassium will decrease. In type 2 it will increase, that is hyperkalemic. This is very important. Okay, and usually you can see pH is usually it's like more in the type 1. Then we have nephrocalcinosis, and the main thing is all types will have NAGMA, normal anion gap metabolic acidosis. So this was all the things about this chapter. There are 5-6 important points which I am discussing. First is broadcast, where it is seen. Broadcast is seen in CKD more than 18, acute tubular necrosis. Then is salt losing nephritis. Nephritis is losing the salt. What will the answer? Interstitial nephritis. Salt losing nephritis, interstitial nephritis. Then is Cockcroft Gault formula. This I told you. Okay, this is used to calculate what? EGFR, right? A patient at risk of contrast induced nephropathy. Okay, whenever you have contrast induced nephropathy, answer will be, it will be diabetic, right? Whenever you have dose of insulin in CKD, okay, dose of insulin in CKD, that means what? Decrease in 80% of the total. Okay, whenever you have most common cause of nephrotic syndrome, okay, that was of minimal change disease. And AV fistula result in what? Arterialization of the vein. So this was all about this chapter. Thank you guys. I hope you liked this, and we again make some more stuff for you. Thank you guys.